It says the webinar is now live.
Afifa, do you want to maybe try see? And Afifa, I don't know if you want to quickly introduce yourself as well.
Sure, I'm Afifa Hamilton, and I am also the co-chair of the Public Health Genomics SIG. I work for Cigna Healthcare and Utilization Management and was a pediatric genetic counselor in my past life. And I have both my MSGC and also an MPH in public health genetics. So public health has been near and dear to my heart since I started grad school.
Great, thanks, Afifa. And I have a slide later on myself, so I'll wait for that. But we are hosting this webinar series to highlight applications of public health genomics in genetic counseling and genetic services more broadly. And we're starting off our series today with this webinar focusing on successes and challenges to implementing population screening programs for genetics. Afifa, can you explain the CEUs? Sorry.
Yes, so this session will offer CEUs. And a very important thing to note is that you're going to get a link 24 hours after the end of the session that will contain a link to the evaluation. If you do not take the evaluation survey, then you cannot claim CEUs. I will also paste the link to that survey in the chat at the end of the session if you don't want to wait the 24 hours to complete it. And then in terms of CEUs, we are approved for our whole series. Our intention is to pay for Public Health Genomics SIG members who would like to claim CEUs for this series. That funding is dependent on the number of individuals who want to claim using that pathway. But that's something we'll address once we have a little more info. And then for anyone else who's claiming CEUs, you will be able to claim them, but our SIG will not be funding those. So you'll be required to pay the typical $25 CEU fee to NSGC like you would for any other series or session.
So it's not too late to join our SIG. But I'm going to get us started off today. So I'll be providing us with an overview of population screening and how this really ties genetics into public health and population health practices. And then we're going to be hearing from our speakers. We're really lucky to have Bret, Alanna, and Kelly with us today. And they'll be introducing themselves and the work that they do after I give that brief overview. And after that, then we'll go into a moderated discussion. Depending on how you found out about our panel, I did circulate the questions in advance. We are focusing on the roles of different stakeholders in service delivery with a focus on engagement of those stakeholders and equity. So very excited to be talking about that with you all. And hopefully we have time for an open Q&A at the end of the session. My contact information is here. If you find that you're really interested about any of these topics, I'm always happy to chat, so feel free to reach out after today's webinar. The videos will be uploaded to YouTube shortly, and we'll be disseminating that link as well as making it available on our webpage. So with that, I'm going to get started. So the first thing I wanted to make is this distinction between screening and diagnostic testing, where with screening, your goal is really to use red flags such as different biomarkers to identify at-risk groups that then need diagnostic testing. And this practice of screening is what I want to highlight because it's what really aligns us with public health, where the emphasis is on population health and stratifying groups by risk. So there's this idea of precision public health, which uses new tools to add precision in your ability to risk stratify people and groups. And I'll highlight in a minute how new areas of screening and genomic medicine are really using a genetics first approach to screening that's very much aligned with this practice of precision public health. But back to this slide, this first step of screening in genetics at the population level is again aligned with public health, where your unit of care is the populations and groups of people. So when you build screening programs or tests, that's what you have in mind, groups of people. And this is very different framing for much of clinical care, which focuses on diagnostic workup in the individual. But both of these are very necessary activities in genomic medicine. So here you see opportunities for screening throughout the lifespan and how these screening practices are complementary to diagnostic care. So, prenatal and newborn screening are probably familiar to everyone, as is carrier screening. But more recently, we've seen an expansion into adult screening for common genetic conditions, particularly in cancer and cardiology. And this is where some of our speakers may discuss genetic first activities. So in terms of the process for selecting what we screen for in population programs, this is where we, again, really integrate with public health practice. And some of you may recognize this list from Wilson and Junger, 10 criteria for thinking of screening conditions. It's usually taught, I think, in the context of thinking about newborn screening. But you'll see that evidence frameworks like this for determining conditions to screen for really rely on public health utility concepts. So for example, prevalence of a condition, morbidity and mortality in the population, access to actionable treatments, and cost effectiveness of screening are all considered. So this is very different from thinking about clinical utility or personal utility, like we might think about for our individual patients. Although I do want to mention that those should not be mutually exclusive. So you may be wondering what exactly is a population screening recommendation, and I want to acknowledge that the process for synthesizing evidence to recommend screening practice isn't as clear. So you'll often find that screening guidance comes from multiple sources at different levels of the healthcare system. So guidance from agencies such as the CDC, different state public health departments, medical societies, even policies from different payers or individual hospital policies. So this variability in recommendations makes it hard to standardize care unless there's alignment across stakeholders. So as one example of this type of evidence evaluation going into whether or not something is recommended for screening, we have the CDC tier system. Many of you have probably heard about the tier 1 conditions, and you can see how different evidence is reflective of public health utility principles to create these recommendations. For the bulk of our discussion today, though, we wanted to focus more on implementation. So assuming that you have a recommended screening guideline, how do you now implement a program to do this? And I want to highlight just with this last slide that it's a real phenomenon, though, that there is variability even before this step of implementation. Oops, sorry, one sec. Can everyone hear me? My thing is bugging out a bit.
Yes, we can hear you.
Oh, there we go. So when thinking about implementation, some of you may have heard about the translational spectrum. I want to focus on this last row here, T0 to T4, this newer nomenclature. So in terms of thinking about translation, you've probably at least heard the phrase bench to bedside. So within the translational spectrum, you'll see that basic research is really your far left. But this idea of translating care to impact the individual and patient care is really only in the middle. Beyond that, there's really a need to translate care to communities and populations from a public health perspective. And these processes aren't exactly linear, but it's a good reminder to think about this spectrum to hold ourselves accountable to supporting community health in our practice. So today, I mentioned that our speakers are really focusing on implementation, which is the later stage of translation. So their activities that they're going to highlight in today's panel discussion are really focused on activities of dissemination and implementation and measuring our impact in the community. So it's very much complementary to clinical care, which is an earlier stage of translation. But it is a different mindset, again, thinking with populations now as your unit of care and the people that you're trying to impact. And then I have that one last slide before I let our speakers talk, where I just wanted to make one last final comment on where there's kind of another gap introduced into the system between what you want to implement as a program and what it actually looks like in practice. So I think those on the call today can probably empathize that there's a fall off from a screening recommendation where you might have like a guideline, for example, backed by a medical society, and that ends up looking very different in terms of the intended uptake and adherence and what you actually see in practice. So this figure here just highlights some of the steps where you get that attrition. So thinking about awareness, acceptability, logistical feasibility, and actually changing provider actions are all kind of areas that provide potential barriers to implementation and putting that into practice, real life practice. So I hope with this overview, I've highlighted why population screening is not as straightforward, everything from kind of the variability in recommendations even made, the difficulty of then implementing a program for that recommendation, and then the challenges of actually changing individual practice are all areas where we've had successes, but probably more often challenges. So now I'm going to let each of the panelists introduce their work on population screening efforts in different settings. And you'll see that they'll highlight different aspects of what we've gone over in this introduction. And if you have any clarifying questions about the intro, please email me. Or if you want to use the Q&A, I'll try to answer your questions as the speakers are talking. So with that, I'm going to hand off to Bret.
Good morning, everyone. I'm Bret Hutchinson. You'll notice first off that I've been growing a beard for a while. I've been growing it ever since the beginning of the pandemic, and I'm happy to say that its days are numbered. So I'm going to be getting my first vaccine next Tuesday. So that's when I.
That's a new hobby. I haven't heard that.
Yeah, that's been taking up my time here. So yes, I'm a program specialist at the California Genetic Disease Screening Program, focusing on program standards and quality assurance for the prenatal screening section. So California, to my knowledge, is now the only state with a statewide prenatal screening program based on from a government entity. So I began in this program as a case coordinator for individual screening cases. I later worked on daily logistics and oversight of the case coordinators, and now I focus on program standards and quality assurance for quality for genetic counselors, as well as amniocentesis and CVS practitioners, and general flow of care once the patient transitions from the level of screening to the level of diagnosis. And I have more information about our program on the next slide. Okay, so the California Prenatal Screening Program exists to ensure that prenatal screening services and follow-up diagnostic services, where indicated, are available to all pregnant women in California. Currently, we still use a biochemical screen. So we screen for Down syndrome, trisomy 18 and 13. I lump those two together because it's the same analyte pattern of the biochemical analytes that we use to detect those, as well as neural tube and abdominal wall defects and Smith-Lemli-Opitz syndrome. And for those who come out screen positive through our program, the state will authorize payment at a prenatal diagnosis center for genetic counseling, ultrasound, and diagnostic testing. This is a self-sustaining fee-based program, so we're not drawing any tax money, but we are paying close attention to the cost effectiveness of our care. But it is mandated by state statute that Medi-Cal and private insurance cover our screening fees. So Medi-Cal being the California's implementation of Medicaid. So once the fee is paid, that covers the screening, and an additional amount is pooled together so that those who come out screen positive can draw from that pool of money to have services mentioned above at a prenatal diagnosis center. Additional functions of our program include maintaining standards for these prenatal diagnosis centers that I mentioned, as well as standards for amniocentesis and CVS practitioners, and also consultative sonologists, for what that's worth. Our program is also a source of research data for publications on prenatal screening and diagnosis. The website for our program is a big long gobbledygook. So if you just Google California prenatal screening, you'll be able to learn a lot more about the California prenatal screening program. And that is all I have to say about it now.
Great, thank you, Bret. Next, we're going to have Alanna talk about her efforts with Lynch syndrome.
Well, hi, good afternoon, everyone. Welcome, and thank you very much for inviting me here today. So I am currently an investigator at Geisinger, which is a health system in rural Pennsylvania. My work focuses on basically implementing precision health programs in healthcare systems in general. So I do a lot of work in multiple programs around genomic screening. So the one I'm going to focus on today is one related to Lynch syndrome screening and implementing universal Lynch syndrome screening programs. I do also focus on alternate service delivery models, other population screening programs, things like that as well. But this Lynch syndrome program is one I'm actually, this is a 5-year moonshot funded grant from the National Cancer Institute that we have to study across multiple organizations. And I have been here at Geisinger doing this work since 2014. And I did a lot of this work as well, implementing genomic programs prior to that, as from another health care system at Kaiser Permanente in Colorado, which is where I also became part of what is this healthcare system research network, which is how I do study across multiple healthcare systems and look at implementation of these programs across multiple healthcare systems. So you can go to a next slide where I will talk about so this specific program called Impulse, this is the name of the grant, is around implementing universal Lynch syndrome screening in multiple healthcare systems. And as you all know, Lynch syndrome being what was on Hannah's slide is a tier 1 condition. So we did this looking at the implementation of universal Lynch syndrome screening programs with an idea to then utilize the tools from implementation science, particularly to help us understand and compare the decision-making at the organizational level, as well as at the individual stakeholder level, to see the impact on implementation of these type of programs across multiple healthcare systems. We do have 9 healthcare systems within this grant and or program, and that we're looking at. Some are within the healthcare system research network and our healthcare systems like Geisinger and Kaiser's, and we have a couple that are outside, and fee-for-service programs as well. So we're looking at that variability between the organizations as well as within organizations. And the goal is to determine or create organizational level toolkits for implementing, maintaining, and improving these type of programs. And really to use our bigger overarching goal is not just for Lynch syndrome screening, population screening, but to understand it as a use case, or use it as a use case for implementing genomic medicine in general. So these toolkits that we're hoping to create will be hopefully a model for other programs as well. And so, in this case, what we did is we've got these 9 healthcare systems, and we have purposively selected them so that some have no program implemented, even though the recommendations from EGAP to implement universal screening for Lynch syndrome, meaning starting at or systematically screening all individuals with colon and endometrial cancer to screen their tumors to see if they need germline testing for Lynch syndrome. The recommendation has been out for about a decade, but we still have healthcare systems that haven't been able to implement it, and we want to try to understand why. We have some that can implement it partially, and others that have been able to optimize their programs and are actually now looking at evolving those programs and asking questions like, when do I do panel testing of everybody instead of doing the initial screening with immunohistochemistry or the tumor screening, or when can I use some other tumors like tumor sequencing tests or something instead, and when do I replace that? And so we've got what we're doing is interviewing multiple stakeholders across all of these different organizations to help us understand what is it that helps these organizations implement programs, or what keeps them from implementing programs, and what proportion of that is individual level knowledge, attitude, and belief of the clinicians and the champions within the organization, and what of it is the organizational contextual factors itself, such as the way the organization is designed, and things like that may be keeping or facilitating implementation. And then our toolkits that we're not finished with the grant yet. We're still in process, but we are in the process of analyzing our data and getting to develop these toolkits such that, we're actually, it's not just implementation. There is initial implementation, there's maintenance, and there's this optimization as well. And so we hope to really create these tools, including tools that help people answer those questions related to costs, and that seem to be a big piece of implementation. And that's all I'll say about that for now. And happy to answer questions later.
Great, thank you, Alanna. Also, I noticed we had a chat. I thought we just had a Q&A. If people want to introduce themselves and if they do any similar work, we'd love to hear from our audience. But with that, I will now move to Kelly.
Thank you. Hi, everyone. Good morning. I'm over here on West Coast time, so it's still morning for me. I'm happy to be here, though. My name is Kelly Tangney. I am a genetic counselor and head of clinical services at Color, and also the lead genetic counselor for the All of Us research program genetic counseling resource. So I've spent most of my career working on adult onset hereditary cancer and other conditions, but do have a particular passion for population screening and public health. So happy to present my experiences today. If you want to move to the next slide. Just a little conflict of interest disclosure. I am employed full-time and have ownership in Color Health. And the slide that I'll talk about next was based on my experience here at Color. All right, so for those of you who aren't familiar with Color's model, we're focused on bettering the health of all people, and that includes bringing access to clinical, high-quality genetic screening and counseling at a population level. So to accomplish that, we've built necessary technology and infrastructure to support this, and we've broadened the way we reach populations through multiple avenues and partnerships, which I've highlighted here on this slide, and I'll discuss more in detail. So I'll explain these 5 kind of buckets and categories we think about that we've implemented to help us reach a broader population and how we've engaged individuals through these different avenues. So first off, on the left, genomics research programs can allow for targeted or broad population screening. Color has partnered with several research partnerships, most notably, probably to this population, the All of Us research program, which is focused on the recruitment of at least 1 million participants across the US who more closely represent the diversity that's present in the United States, but has not historically been present in traditional genomics research. We have not yet begun to disclose test or screening results to All of Us participants, so the statistics that are presented below on our research projects are more representative of our other partnerships. But on average, the age of individuals undergoing screening through these research programs that we've partnered with, such as Wisdom, Magenta, Gentleman, and others, is about 53 years old, and about 61% would meet NCCN criteria for hereditary cancer genetic screening based on personal and family history. And in that population, we see about 5.5% positive rate having either a pathogenic or likely pathogenic variant. Secondly, we've also partnered with several large health systems to provide education about the benefits of genetic screening and precision healthcare, as well as genetic testing and counseling services to a health system's provider and patient populations. And so for this model, the health system, such as the ones listed here that we've partnered with, collects the patient sample, and Color uses our technology to integrate our test results and counseling notes into the health system's electronic health record. Several of our partnered health systems offer testing through primary care physicians. So you'll see below that only about 36% of individuals that use Color's testing and counseling through the health system approach would otherwise meet NCCN criteria for testing, but just over 7% have a positive finding. And then more traditionally, testing, of course, can be ordered by a patient's own provider. Some benefits of allowing this broader population testing model to be a method to which healthcare providers can order genetic testing and screening include lower cost testing options for patients that don't meet more strict NCCN criteria, but that could still benefit from screening. Population screening programs can allow for more broad cascade testing in international or uninsured or underinsured relatives. And providers may not be as well versed in genetics, but can benefit from using a post-test counseling service through certified genetic counselors. Not surprisingly, a higher percentage of individuals from ordering providers do meet NCCN criteria. And we also see a higher percentage of positive results at 12.6%. Fourthly, individuals can come directly to Color's website to order testing through our third-party network of physicians, a process that has been dubbed as kind of consumer-initiated testing. By offering this service, we're able to provide more accessible genetic testing and counseling services. And this population is undeniably broader than a traditional genetics clinic. However, it is not actually representative of the general public. In fact, over half of these individuals actually meet NCCN criteria. And we see this bias mainly because people are self-selecting for screening, right? Some are choosing to undergo screening because they want to be proactive and they're very motivated about their health. Some want answers for relatives or are just generally curious about genetics. And others may have previously been denied by genetics testing through insurance or provider. Though the positive rate in this category of clients is actually quite high, just under 12%, similar to the provider ordered channel. And then lastly, some employers have begun offering genetic screening and counseling services as a covered healthcare benefit to their employee populations to improve health outcomes and reduce healthcare costs. So at Color, we do offer employee education events and engagement opportunities, educating individuals on the importance of screening and the benefits of that, as well as limitations and pros and cons. And these tests are ordered through our third-party network of physicians, similar to our direct client flow. This seems to be a relatively healthy and younger population with a lower percentage meeting NCCN criteria for hereditary cancer screening, but with just over a 5% positive rate. So happy to answer questions as we get to the panel, but I'll pass it back to Hannah for now.
Great, thanks, Kelly. And then I'll just introduce myself. As I mentioned, I'm one of the co-chairs for the Public Health Genomics SIG. I am currently working at Stanford. I actually do a lot of population screening programs related to familial hypercholesterolemia. A lot of my experience probably overlaps with Alanna of thinking about the institutional kind of organizational level of implementation, but similar to Alanna, I also then contribute to different multi-site studies or national efforts to help address some of those multi-level barriers and have more alignment again across the healthcare system, using what we learned from clinic to inform those kind of national policies. And similarly, I'm now transitioning into thinking about common disease, genetic-based screening through polygenic risk scores, which I'm not going to talk about today because it's not quite at the same level of implementation as the other conditions we've been featuring. If you want to think about a translational spectrum, that is not quite yet at the T3, T4 phase. There's a lot of things to figure out with it still. I'm going to try to stick to moderating, but there are some unique attributes around FH screening in the cardiovascular setting. So I might chime in here and there with some of the efforts we're also doing at Stanford. But I think with that, we will move on to panel questions. The first one that we wanted everyone to discuss is what they see as the role of genetic counselors or genetic counseling for population screening. And we unfortunately can't get videos to work to know who wants to talk first. So everyone just jump in, I guess.
So I'll jump in first, I guess, and I'm interested to hear what the others say. And I hope this is what you're looking for, Hannah. So in our program, you think about Lynch syndrome screening, what I can say from what we're finding out is across these multiple organizations, genetic counselors can be the champions. And in fact, a lot of times they are the champions, maybe not necessarily in terms of the initial implementation, although sometimes they can be. But they are certainly champions in terms of optimizing programs because, again, universal Lynch syndrome screening, and I would argue many population genetic screening programs, including FH and others, requires coordination across multiple departments. And that's something genetic counselors are really good at. And so when we look at why some of these programs are functioning and optimized and others aren't, what you see is their tracking, is their ability to make sure these handoffs are happening between these departments. And a lot of times genetic counselors can be instrumental and champions of that. They can be the ones who are evaluating the data. So it's not just the pre-test and post-test counseling, but it's really in making sure that these programs are functional and serving the purpose that they're intended to do, basically having the public health impact that they are intended to have, would be the way I would say that.
Thanks, Alanna.
Yes, I agree. I think, genetic counselors, even though we are small in number, are trained to help at this level. We're trained to take complicated information and make it digestible and tailored at an individual level. So really taking a population screening model at a large level and kind of breaking it down to where many individuals can understand the benefit of it and who would be most useful to have and undergo that type of screening or testing. I think, there are ways for us to continue to evolve as genetic counselors, be able to scale up to a larger level. And some of that, I think, has to do with, again, just educating others and automating certain processes to scale at that larger level.
Good morning, all. I would certainly agree with Kelly. There is a limited number, excuse me, of genetic counseling hours to go around. So if we're talking about the kind of screening I'm involved with, prenatal screening, in California, say, it is very difficult to do pre-test or pre-screen counseling at the population level. I've seen centers try various methods such as group classes, pre-recorded educational sessions, and development of educational materials. And of course, all of those have their limitations. I have been involved with a lot of counselors who do post-test counseling. And in the area of prenatal screening, in particular, aside from informing about the test itself and its results, there has been a huge role of genetic counselors here, pointing out the limitations of the tests that patients have taken to clear up any confusion left by the referring physicians or the labs that promote the screening tests. And of course, to help patients come to a place where they can make their own informed decisions about what kind of additional follow-up services, if any, is most appropriate for them as individuals. Aside from the post-test counseling, though, there is certainly an additional role for genetic counselors in advocating for what they hear patients needing that might or might not already be provided by a public health system such as ours. So genetic counselors have a very important role they can play in taking patient concerns to some of the advisory committees that our program conducts and which I have run, so that as our program develops, we can take those into account and make sure we're addressing them. So advocacy is a huge thing as well, aside from the actual post-test counseling itself.
Yeah, I would echo that actually, but I was going to mention, I think bringing person-centeredness into the conversation is really important, or has been in my work, where I mentioned that a lot of what goes into thinking about programs for populations is thinking about the public health impact and public health utility. And those, again, shouldn't be mutually exclusive from thinking about personal utility for patients. And I think having that insight of knowing what the community wants and, what other priorities are going on, and the, holistic conversations that we get out of genetic counseling, and having that happen at the policy and research level has been really impactful in changing designs of programs to be more suited for the communities they're actually trying to reach. So I think it just helps with alignment there. And that we might, we're talking about health equity in a little bit, so we'll probably touch again on that later. But I think we'll move on to the next question, unless Alanna or Kelly, if you guys want to add anything else.
Okay. I think what you've said flows nicely into the next question, Hannah.
Perfect. Look at that. Semi-intended. So our next question then is, what is the role of the patient or community in guiding service delivery? And maybe the better question is, how do you have that voice of the community and patient in these programs that are meant to serve them?
So I guess I'll start again. This is, in our work at Geisinger, I guess one of the ways we would say it is we try to do this. We try to keep them at the center of everything we do. So I've been a proponent of, I've been doing this for long enough that I usually just start from the point of let's go ask. And I will always also say, along with asking our stakeholders, our community, our patients, what do they need? How does this work for them? We actually need to listen as well. But there are multiple, I don't know what you're trying to get at this, Hannah. There's multiple modes that we use. We can do deliberative engagement. We have advisory boards. We have patient partners in our research projects, in our clinical projects. We really, we have not just patients, but the community, the external community to Geisinger, the external community in any of our multiple healthcare systems. Many of our healthcare systems that we work with for the Impulse Project have community engagement groups and programs. We also have other stakeholder programs as well. So we have boards of our primary care physicians, our non-genetics clinicians, which might actually be another question of yours. So I will focus on just the patients in the community. We really do try to engage them at every point. Anytime we have a question, and how do we do this? How do we, if we're thinking of redesigning care, if we're thinking of changing a program, we go ask, and then we listen.
And I'm curious then how that compares, Bret and Kelly, you guys work in such different environments compared to having access to patients in a hospital system. I'm curious how you guys involve patient or community input, and at what point, and how does it impact then your decisions?
Yeah, great question. I think, I fully agree with Alanna that the patient and community voices do need to be listened to, and more than just listened to, but their thoughts and opinions need to be integrated on the service delivery process. One way we've tried to do this at Color, and also as we're implementing and developing all of us genetic counseling resources, is do certain focus groups and things like that, where we have real people looking at our results, our processes, and giving feedback, and then integrating that feedback so that we can make that process better for all. And no matter how accessible we make screening services, it still is up to the patient to be engaged in obtaining and integrating those screenings into their healthcare and lives. So, another avenue I think is, again, education, education at an individual level, but also at a broader community level, so that, and for healthcare providers as well, about the benefits and limitations of screening and how we can increase community awareness and engagement as well.
Once again, I would second that. I think from my perspective, in the state-run prenatal screening program, the guidance we are able to take from patients is often, I'll say, secondhand. It comes from the prenatal diagnosis centers, it comes from the OB offices, and the surveys or anecdotes that they conduct and collect. But once they do arrive, we take them as seriously as we can. In terms of the role for patients themselves, I would say an important role is to stay informed, of course, take information from trusted sources, and even make it clear what your expectations are when you come into the clinic or when you're being telecounseled. I know that in our program, an important issue has been patients' knowledge of what tests are being ordered for them. So an important role for patients in the prenatal screening community is to know what tests are being ordered for you, and know what the implications of those tests might be. To advocate for yourself, and if you are a more proficient in a language other than English than in English, there may well be resources available for you in other languages. So self-advocacy is certainly an important thing. For others, other clinicians, as far as we're concerned, include general practitioners and OB doctors and staff. It's important for them to establish good working relationships with service providers. In our case, those would be the case coordinators, and also our administrative staff at Well through our advisory committees that we run. It's important for them to know whom to contact with questions. And I will even add to stay informed about the tests that are available. Currently, through our screening program, there are multiple separate tests available between biochemical and cell-free DNA screening. It's important to take the information for those in context and independently choose which methodologies are going to be best for your patients and your population.
Great, thank you, Bret. I'll just highlight one of the things that I've really had to think about when transitioning from individual patient care to thinking about population health is framing it, I guess, the right way, or coming up with the right evidence. I think in our joint counseling sessions, a lot of what we do is person-centered decision-making, and a patient's preference can, guide their decisions in an anecdotal way. But when you're trying to come up with a program that's person-centered, you need a different level of evidence of that patient input. It can't just be anecdotal. So Alanna, we've taken the same approach of having a patient advisory board for our programs to, more systematically be able to point to this being the preference of the community. It's important to have literature that has more patient-centered outcomes and input. But yet you have to be a little bit strategic about how to, again, kind of translate that voice from what would be okay in a clinical setting to what is more appropriate at the policy and research agenda setting. I don't know if that's been the experience of others, but I think that's one way that I've found that I can be a good advocate with my genetic counseling skill set to try to think about just different levels of stakeholders in the healthcare system and what speaks to them.
Yeah, that's a wonderful way to put it, Hannah. And I would also say, along with that, I think the huge benefit of those other voices is to sometimes help us do things and create things at a population level that we may not have considered coming from our individual patient decision making. I often talk about a project we did a number of years ago with some patient-focused reports. And honestly, without our patient advisors, we would not have tested a version of the report that ended up being, the one that everybody, clinicians and patients, liked the best and found the most useful, because in our normal way of interacting with patients, we would have not necessarily used something that complicated and comprehensive. And so having that voice and having that reminder that, we need to think about it differently, and then to try it and in multiple additional stakeholders is huge.
Yeah, agreed. That kind of starts to tie to this next question on the topic of communities. I'm wondering how you all or your organizations think about health equity in your service delivery, and as a related, though distinct concept, cultural sensitivity. Translating what the community needs now are into like actual operations to support health equity in your practice.
I think this is an ongoing conversation and issue. I don't know about the other organizations for Bret and Kelly, but I know it's just an ongoing issue here. We may have training programs. We try to do everything we can. And I can say in my own research projects, we try to make sure we have multiple healthcare systems so that we get those differing opinions. Geisinger, we're very rural. We partner with other organizations that may have different racial, ethnic diversity as well, maybe more urban, and trying to see what is the same and different in all those different contexts as well, just to make sure we are being sensitive all the way around. I can say even in a recent project, not the Impulse project, but another one of screening for genetic screening for ovarian cancer. And, just even the thinking of, rather than just saying women, but individuals who have had ovarian cancer or individuals who were assigned female at birth, needing to pay attention to that. And that's a new way of thinking about it for us. And that came out of our community advisors.
Yeah, health equity is pretty much at the center of the purpose of the California prenatal screening program. There are pregnant people in California who have easy access to a nuchal translucency ultrasound, and there are those who don't. And the same can be said for the most basic insurance coverage, level 2 ultrasound, prenatal diagnostic testing, and even screening tests with amazing performance metrics. And so our purpose is really to elevate those who don't have access to any of those things otherwise, such so that they can, if it's appropriate for them and if they want it, to have access for that kind of testing, so that diagnosis can be available for those who could benefit from the most of it, regardless of their background. So coverage for screening for our program in California is mandated by state statute, both for private insurance and for Medi-Cal, which is something that we're really proud of. So you can get your presumptive eligibility for Medi-Cal and get your screening done. Another issue of equity in California is geographic equity. So for those who live in rural counties who are otherwise a long drive away from those who practice any kind of prenatal diagnosis, or from being able to sit physically in with a genetic counselor, we can implement policies to make it easier for centers in rural counties to practice. In terms of cultural sensitivity, thinking about prenatal screening and diagnosis requires thinking at some point about pregnancy termination. And while that's not a covered service under our program, we do ensure that all prenatal diagnosis centers have at least a plan for referral if that is what a patient requests. Should I say it? An important point underlying that is the concept of non-directiveness, which is what all genetic counselors are going to be familiar with. So patients, as long as they are counseled, are free to elect which steps to take in terms of whether to get any diagnosis at all or any following steps after that.
Yeah, I think from our front, Color has always been really focused on health equity. There are a lot of gaps in healthcare and especially in genetics. And I think some of that is coming to the forefront more and more. We have obviously tried to bring down costs of testing and make it more accessible, as well as counseling services. So using our telephone counseling model where we're able to reach people all over the world and also offer screening services to them, to potentially countries or areas where they might not have a genetics professional for hundreds of miles in their area, or be able to even to access that testing or counseling. So we have tried to break down some of those barriers and bridge those gaps in different ways. We do have several programs like our Color for All, where we provide free testing to certain healthcare organizations. And that is funded through our company and also by our clients who can donate to that program. And then we also have our family testing program, which we provide $50 screening for individuals with a known familial mutation in one of the genes that we test for that's been tested at a CLIA and CAP accredited laboratory. In terms of cultural sensitivity, that's something that we've really been focused on as a genetic counseling team at Color. We've had several team-wide discussions about it, but also have invited many external guest speakers to come talk about culture engagement and just thinking about our own biases as individuals, as genetic counselors. We've also established a internal genetic counseling book club and different educational events that's really, I think, focused on those unique topics. So something I think, as Alanna mentioned, is an ongoing conversation is definitely something that will be an ongoing thing that we think about at Color, but also something that I think we as a profession are trained to think about and to provide socially and culturally competent care. And so that's something I think we're uniquely trained to do and should continue to expand upon.
Great, thank you guys. I did want to bring this back conceptually to the idea of reach. If you have a recommendation that something should be at the population level for, like all women, ages, whatever, or all men within this age group, thinking about that as a population to reach and having that in mind and trying to target that as much as you can. Because I think the tendency is that, especially with genetic services, it's accessed by convenience, and any additional added screening program or innovation to the system only widens those disparities. So it's the people that tend to have good insurance or know what's covered by their insurance or are able to easily get to the clinic that are already receiving services, and adding on a new program that's technically accessible, but that people aren't aware of or already, accessing the healthcare system in general, it's only going to widen that disparity. So I think it's really important to take a step back and think about your target population and communities, going out there, just seeing how they think about health, how they access their health services, why and when they would go to the doctor, and trying to integrate your programs to already work with what works for them is really important. And also starts to get at that cultural sensitivity depending on how you subgroup who you're talking to. But I think just trying to have that in mind of, what does this actually look like in practice? And are we reaching the people that we want to be reaching and not just doing things based on convenience is just really important to keep in mind. And I'm sorry, because I noticed we're at time. There was a question about engaging other stakeholders. Since we don't have time for that, I'm going to follow up. There is a really great stakeholder map put together by the Public Health Genomics Week in May that highlights all the different people that really have essential voices. This SIG will also be putting together a video series to highlight different public health genomics teams and how different training backgrounds such as genetic counseling or having your MPH or your JD all kind of complement each other to work together on some kind of public health activity. But with that, and I'm sorry, panelists, that we didn't get through all the questions, but I did just want to leave time to flash this up that we have upcoming webinars as part of this series. Registration will again be free and open to all, and we'll have videos on YouTube